Well, welcome to all our visitors today, and especially welcome to our speakers. My name is Todd Tuttle. I'm a surgical oncologist at the University of Minnesota, and I've been involved in global breast cancer care for over a decade. I want to also introduce Dr. Jennifer Morgan, who is the co-director of this program seminar series.
Hi, everyone. Just for those I don't know, I've worked kind of I'm a medical oncologist at University of Minnesota, and I've worked kind of in the East African region, mainly in Rwanda, Malawi, and now most of my work is in Western Kenya and Eldoret, for anyone who's familiar with the AMPATH partnership. It's a pleasure to be here, and thanks for coming.
We started this global breast cancer seminar series to try to provide some formal educational opportunities for healthcare workers who are treating breast cancer patients in low and middle income countries. And we also want to create a community of experts throughout the world who are really trying to make an impact on the lives of breast cancer patients in low income countries. We have decided to settle on this seminar series where we have formal presentations with discussion and questions afterwards. But this may eventually evolve, and we really want to know what your needs are to help us decide how this might evolve to become the most effective type of seminar series. I'm going to check out a little bit early because of another commitment, but Dr. Morgan was going to lead the question and answer and discussion at the end of the second presentation. I think the best way that this will be an effective mechanism or seminar series is if we have a lot of people involved. So please feel free to share this link, website, to all of your partners who may have an interest in improving breast cancer outcomes. Last month was our kickoff for this seminar series. It was a presentation by Dr. Benjamin Anderson, who is probably the leading expert in global breast cancer in the world. His presentation now is on our website. So if you missed it, feel free to hear his outstanding presentation. Well, today we are talking about one of the most important aspects of breast cancer care, and that is genetics. And we have two outstanding speakers today. I'll introduce Dr. Peter Beitch first. Dr. Beitch is a practicing surgical oncologist who is trained at the MD Anderson Cancer Institute and the John Wayne Cancer Institute. He's been involved in breast cancer clinical research for 30 years and is an author on multiple very important research papers, including sentinel node biopsy, breast radiation, genomic testing, and breast cancer genetic testing guidelines. He published an outstanding practice-changing study in the Journal of Clinical Oncology in 2019 that really changed genetic testing guidelines in the United States. And I probably quote his paper once a week. In addition to that, he has built a radiation oncology center. He's founded a breast cancer education company. He is been very involved with the American Society of Breast Surgeons. So it's a pleasure to introduce Dr. Peter Beitch. Thank you, Peter.
Wow, thanks for that introduction. Let me share my slides and we'll get rolling. All right, can everybody see that? Somebody please say yes.
Yes.
Can you see? Okay, good. All right, fantastic. All right, well, we're going to talk about breast cancer risk assessment today. We're going to go over current screening guidelines, the risk models that I think are going to be easy for you to access and use wherever you are. We're going to talk about a little bit about the future, which is image-based risk assessment. Then we're going to go into genetics and talk about germline genetic testing. We're going to tell you a little bit about single nucleotide polymorphisms and the polygenic risk score, and then how that can be modified with ancestry. Here's the problem. It's going to be 300, or there was 300,000 cases of invasive breast cancer in 2023, and another 55,000 of DCIS with 44,000 deaths. This is U.S. data. Here's the current screening guidelines. It varies a little bit. Probably the most conservative is the United States Preventive Services Task Force, USPSTF, where they really don't even start till 50, and then it's every 2 years, and then over 75, they don't recommend it. American Cancer Society is definitely a little broader. Individual choice till 45, and then once a year till 55, and then every other year from 55 to 74, and then age cutoffs are really, I think, less important than physiology cutoffs. So if you're still in good health, you should be getting mammograms, as it can still detect. You can still get screen detected breast cancers. And then, of course, the American College of Radiologists, which may have a vested interest, wants it to begin once a year at age 40 and then up till 75, and then decide again about physiology versus age. Let's talk about risk assessment. So it's something everybody can do, primary care or OB-GYN or breast surgeons or medical oncologists, and usually want to begin that between 25 and 30. I do reassess this often because personal history changes, family history changes. You know, your father's sister gets a breast cancer, and that will alter your risk in some of these models. The risk does stratify patients and identify things like who needs germline genetic testing, or and then allows for a rational both imaging and follow-up plan for those patients. In America, at least, doing a risk assessment and having a high risk will facilitate supplemental imaging approval by the payers, CMS, and the insurance companies, and then certainly can identify patients for potential risk modification. And you're going to hear a lot about that from Dr. Burke. Here are just a couple of the models and the websites that you can get them at. This is the Gale model. It's been around the longest. It calculates 5-year and lifetime risk. It's easy. It's a very 7-question survey. It really has very little family history in it. It's basically was used to identify high-risk patients who could benefit from chemo prevention, and was used in the NSABP prevention trials. And about a third of the women will be high risk by Gale. So it's not too differentiating. BRCA Pro really is about calculating your risk of BRCA1 and 2 mutations. It's got a way more extensive family history, including the ages, and not just breast cancer, but ovarian cancer. Way better than Gale at that. It will give you a breast cancer risk, but it's mainly used to identify people who need genetic testing. NCCN, again, gives you patient management guidelines once you've had a genetic mutation. And there's the website for it. Not a great risk model at NCCN. Here's one specific for Black women, or at least Black women in America. Calculates your breast cancer risk at 5 and 10 years. It's based on a data set of only Black women. It includes weight, interestingly enough, at 18 and their current weight. So BMI at 2 different time points. It does have family history, and it's really way more accurate in the Black community, at least in America. Boadicea gives you a lifetime risk of breast and ovarian cancer. It's a very extensive questionnaire, including family history, height and weight, gene history, breast density, and it has incorporated alcohol intake, which we know is a risk factor for breast cancer. However, it does not include breast biopsies, which is actually can be a profound risk factor. Calculates 5-year and lifetime risk. Also will give you a risk of BRCA1/2 mutation. It's very commonly used in Europe and can be used for identifying risks so that you can get supplemental screening, particularly with MRI. And there's the website. So um, I'd say the most popular one in the US is Tyrer-Cuzick version 8. Again, it gives you 5-year and lifetime risk. It has a very extensive family history with all the Gale questions. It includes breast density, which is incredibly important. We'll talk about that in a minute. Hormone replacement therapy, BMI. It also gives you a calculation of BRCA1 and 2 mutation risk. We use it every day in the clinic, and it allows us to risk stratify so we know how often we need to see them and if we need any additional supplemental imaging. And we print out the Tyrer-Cuzick risk assessment if we need to get supplemental breast MRI for dense breasts. Here are the risk factors, family history, that's genetics basically, and looking at breast and ovarian and other cancers in both first and second degree relatives. History and physical exam. The things that are important are their gynecologic history. When do they start their periods, menarche? Have they stopped their periods with menopause? Have they had births either early, which lowers your risk, late, which actually increases your risk, or no births, which also increases your risk? And then, of course, height and weight, BMI, affects risk. Benign breast biopsies, the number of biopsies, and then the pathology is very important. And then breast density is critically important and is a risk factor and also can hide cancers. A lot of women have breast density, at least in the US. Here's a pedigree. There's a website if you need a website to have a pedigree that you can type in and print out. It's people, it's not just the breast cancer, it's the other cancers in the family, not just the mother's side, but also the father's side. The more family history you can get, the more accurate your risk assessment will be. Things we just went over with history and physical, it's a timeline of a woman's life, when they start their periods, when they're having children, when they stop their periods, and are they on hormone replacement? And of course, height and weight. Breast biopsies, that's included, just the number is included in the Gale model, but in Tyrer-Cuzick, actually the pathology of the biopsy is important. And if you look at the way the biopsy pathology changes scores, if you haven't had any, very low risk, the biopsy, but don't know anything, risk goes up. Hyperplasia, and this isn't atypical hyperplasia, this is just hyperplasia, increases risk. And as we know, atypical hyperplasia and, of course, lobular carcinoma in situ markedly increase your risk of developing breast cancer. Breast density, here's just a mammographic depiction of density. And density is described in letters A, B, C, D, D being the densest. And it's a problem for two reasons. The first one is it can just decrease your ability to see a breast cancer within the breast tissue. But we also know that density is by itself a risk factor of developing breast cancer in the future. Current supplemental, these are the supplemental screening guidelines. In this case, for non-dense breast tissue, if you're high risk, you need a mammogram, preferably if you can get it, digital breast tomography, a little more accurate ability to see through breast tissue. And then if you're high risk, again, typically we'll get a breast MRI on these patients. There are some caveats with that, probably the biggest one being claustrophobia. Let's see. Now, if you have dense breast tissue and high risk, obviously you still need the tomography, MRI with and without contrast. You can do the abbreviated version. That's not bad. You can do contrast enhanced mammography. That is probably equivalent to an MRI. So that's sometimes a good alternative if you have it. There's, at least in Dallas where I am, there's only one place where you can get it, so it's not widespread at all. And then I add in ultrasound. I'll be seeing high risk and dense patients at least twice a year, and I do a lot of breast ultrasound, and so I like doing ultrasound and really assessing their breast tissue. No radiation, no contrast, easy to do. So ultrasound I think is a handy tool in the toolbox. But there are problems with the current risk models, and they're population based. They're not well adapted to an individual risk assessment, personalized. It's not adjusted for ancestry. We're going to talk about ancestry when we get to polygenic risk score. You actually have to collect data and you got to put it in the model, and you got to have the model, you got to have it open and plugged in. So you have to rely on the people getting that data in there to get an accurate one. It gets less accurate over time. And then if you have a personal history of breast cancer, obviously, you still need risk assessment for future cancers. We're getting really good at fixing the first one, and I'm personally am seeing more people with a second one. So where do we go with that? Well, it's going to be the future for sure. But we can now look at mammograms, run them through a AI machine learning model, and it can get risk assessment over a short time for the individual patient based on her mammogram. So image-based risk, and it's typically gets a short term. It's a short-term 2-year risk assessment. It's done on standard screening mammograms. Right now, it's a complement to long-term risk. We're all very familiar with long-term risk. We kind of got to wrap our head around short-term risk. Hopefully, it's going to reduce the risk of interval cancers, especially when you're doing mammograms every other year. I think it's important to get this short-term risk. Currently, there are multiple techniques. I just heard about one yesterday that the FDA has approved. So this is in a rapidly evolving field. It's AI, artificial intelligence based. So you know how rapidly that whole field is changing, and so we're going to hear more and more about this on screening mammograms and AI-based risk assessment. So. And again, these are mainly for supplemental screening. The issue really is insurance companies and other payers haven't wrapped their head around it, so they're not. There's still a lot of pushback on getting like a breast MRI for somebody with a high short-term risk. It just it's we're not there yet, certainly as a country or a world. There's plenty of models out there. I don't know who's going to win, but there may be several winners. You put the mammogram through this artificial intelligence or deep learning algorithm, you get a short-term risk. Your risk assessment from that model is completely dependent upon the learning set of the mammograms that were fed into that. Typically, it's 10,000 mammograms or 100,000 mammograms. Sorry about that. Well, who knew that would happen? I'm at a hotel in Madison, Wisconsin, and I certainly hope that stops soon. I'm not going to leave though. If you can still hear me,
We
the
can.
risk,
We
the
can.
2-year
Yep.
risk assessment is in the single low digits. Payers really don't understand this model at all yet. Sorry again. Now let's talk about genetic testing for breast cancer. If you look at all the breast cancers cases, only about 10 to 15% are actually caused by a single gene mutation. Of those single gene mutations, 45 to 60%, probably around 50% are caused by BRCA1 and 2. The thing to remember is different genes carry risk of additional cancers beyond breast cancer. As you see on here, the Lynch genes are on here, right? They do increase your risk of breast cancer, but they also increase your risk of colon cancer, endometrial cancer for some of the genes, and other cancers also. Here are the big breast cancer genes that we worry about. There's BRCA1 and 2. This is the penetrance, so how likely you are to get a breast cancer. This is the frequency in the population. So a gene like P10 is very highly penetrant, but not very prevalent in the population, thank goodness. Again, P53, a little more prevalent, very high risk of getting and developing a cancer. BRCA1, not uncommon in the population, and again, high risk of getting a breast cancer. We're going to talk about SNPs here in a minute, risk SNPs, super common in the population, but individual SNPs, single nucleotide polymorphism, do not increase your risk of breast cancer by themselves. You group them together and they can increase your risk. So how do you determine who needs genetic testing if the patient does not have a cancer? Well, there are tools. Each genetic testing company has a tool. This is Myriad's. It's called My Gene History. Ambry has one. They all have one. Cancer IQ is a common tool that's used in breast centers. BRCA Pro, we already talked about it. It's something you can pull off the internet, plug in the patient information, and you can get their risk of having a mutation. You plug it in, and then you determine whether they meet NCCN criteria, ASBRS, USPSTF qualifications. So a lot of risk models for unaffected patients. Here's that paper that Dr. Tuttle referenced. We published in 19 in the Journal of Clinical Oncology. We looked at 500 patients who met NCCN criteria, 500 who didn't. And as you can imagine, the mutation percent of patients with mutations was essentially the same in whether you met NCCN criteria or not. Oh, thank the Lord. What the ASBRS took that and said, well, I think they set up a committee and they said that germline genetic testing should be offered to all breast cancer patients. They don't have to have it because it's an individual choice, but it should be offered to all of them. And the main reasons you want to do it in affected patients and patients with breast cancer is that it can change the treatment plan for that cancer. If the patient finds out that she has a BRCA2 mutation, she may want not breast conservation, but she may want a mastectomy with reconstruction. So it's important to get that testing. It's also important for targeted testing or targeted therapy, PARP inhibitors. You certainly, if you know that they have a mutation that has associated other cancers, BRCA1 is also associated with ovarian cancer, pancreatic cancer, BRCA2, also ovarian, pancreas, and melanoma. And so knowing what their mutation is, you can also be following them for other cancers. And don't forget about cascade testing their family members. That's not just their sisters, not just their sisters, but it's their brothers, because let's say BRCA1 has an increased risk of prostate cancer. And then not just their siblings, but also their children once they turn 18, and then as well as their parents. I've had patients forgot to test their patients, and they end up developing a cancer. Yay, maybe it'll stay off. So you identify a mutation in a patient. How do you manage them? What do you do? Well, Ask2Me is still around, developed by Kevin Hughes when he was at Mass General. He's now at South Carolina, but the website's still there. I checked it. You plug in what their gene mutation is, a little bit of what they've had as far as surgery goes, their gender, their age, and then see if they've had any prior cancers, and it'll get you a risk assessment. This happens to be a P10 mutation patient who at 25, and if you look at all the other cancers that she's potentially has a risk for, it's here. Um, this is baseline. The green is baseline breast cancer risk in the population. Look at P10, the risk of developing a breast cancer super high in this patient population, but also colorectal, endometrial, kidney, melanoma again, thyroid. And then the other thing that Ask2Me will do is give you a timeline of when they're highest at risk. So that red arrow is at age 40. So their risk is still below 20% at age 40. We start to worry about, once it goes above 40%, I start talking to them about their risk. So as soon as you identify them at 25, you don't have to do everything, but it's good to know their risk so you can plan for their future, and then also screen for other cancers that they may be at risk, that they are at risk for. Now, with a genetic test, germline genetic testing results, you get a germline mutation. That's a positive one. You get no mutations at all. That's a negative report. You may get something that says this patient has a variant of unknown significance, or a VUS. The thing to remember about VUS, the genetic testing company follow those over time. They sort them out. Vast majority of time, over 90%, probably over 95%, these variants of unknown significance end up being benign, so that it's not a mutation that causes cancer. Most of these are just little single nucleotide polymorphisms. And so how do you handle that? Well, you do not manage them at all on their VUS. You manage them on their risk assessment, like Tyrer-Cuzick. That's a Tyrer-Cuzick printout right there. So what are single nucleotide polymorphisms? Well, they're just minor genetic variants that we all have within our DNA sequence. There's a human genome's about 3 billion base pairs, and there's about at least 20 million of these little minor variations, these single nucleotide polymorphisms. Now, by themselves, an individual one doesn't carry any risk at all, but through the genome-wide association studies, the GWAS, we've identified groups of these SNPs that, when put together, can increase your risk of breast cancer. And in fact, they're about 30% of hereditary breast cancer risk is probably attributed to these SNPs. We all have these families that have multiple generations of breast cancer that look like it should be a single gene mutation that's causing it, and you do germline genetic testing and they don't have any monogenetic mutations to account for their breast cancer in the family, probably due to these SNPs, this group of a number of SNPs that together increase their risk. So here's the risk SNPs again. These are common in the population. These single nucleotide polymorphisms, they're common. Problem right now with SNPs and risk assessment, polygenic risk score from SNPs, is that most of the models, the tools that we use, are done on white Europeans. A little bit of Asian population, but not much in African and not much in Hispanic. So the caveat for a non-ancestry adjusted polygenic risk score is that it's really best for white Europeans. Here's a really fascinating study out of Myriad, and it looks at self-reported versus genetically determined ancestry. And if you look African, Black or African, self-reported, very common that they agree with the genetically determined ancestry. But Asian, Hispanic, not so much, the self-reported versus the genetically determined. So we're going to talk about how this affects the polygenic risk score here in a minute. So here again, this is the problem with non-ancestry adjusted when you're just looking at polygenic risk scores. that actually shifts the risk and makes it higher in Black Africans, Asians, Hispanics. And so it's not nearly as accurate with the sort of the standard SNPs polygenic risk score. So what in this case Myriad has done, they have taken a 93 SNP risk score and then also added in ancestral SNPs. So it's not a self-reported ancestry, it's actually a genetically determined ancestry. You combine those two and you get this polygenic risk score for different ancestries. And that's their PRS 149, which is just the 56 ancestry plus their 93 gene SNP panel. And what that does is, as you can see in the upper right-hand corner, you look at ancestry, their SNPs panel, and it lines it up. It's much more accurate when you include ancestry in this. Interestingly enough, if you have a germline mutation, you have a wide spread of a risk. Let's see, here's CHEK2 for example. If you look at all the CHEK2 patients, CHEK2 mutation patients, their risk is around just slightly over 20% lifetime risk of getting a breast cancer. But there are some people that have a 60% risk, and there's some people that have a 10% risk. And so Myriad did a study where they added in their polygenic risk score, and it actually gave you a much more accurate position on that risk curve. Here it is right here. The polygenic risk score adjusted for, in this case, CHEK2 mutation. General population, here's the average risk for CHEK2 mutation, 23%. In this particular patient, when they added in the polygenic risk score, her risk went markedly up. You know, when we start to get into this range, certainly above 40% is when I start at least mentioning prophylactic mastectomies to these patients. There's a lot of variables in who should get that and who shouldn't, based on their psyche and the family history and whatnot. But it's nice to have risk adjustment with mutation patients also. So now that we know the risk, now that we know the germline risk, now that we know the polygenic risk score, what should we do with this information? Well, surveillance, let me tell you how I do it. I use a risk model. Typically, I use Tyrer-Cuzick version 8 and assess them early, 25 to 30. My high-risk patients, which I define as over 20%, I see them at least twice a year. You know, sometimes high risk, very high risk patients, I see 4 times a year. Everybody gets a mammogram. I try to get everybody to get a breast MRI. And then every time I see them, I also do an ultrasound in my office. I get to know their breast and by ultrasound very, very well. AI mammogram risk is coming. Get ready. You're going to hear more and more about that. Genetically test appropriate patients. We will probably get to some point where everybody gets germline genetically tested, but at the moment we're still using the models to determine that. And then polygenic risk score, you know, that's a large percentage of population that have breast cancer have increased polygenic risk score. So that is becoming more prevalent, and right now we also modify it by ancestry. So with that, no more beeping, and I'll turn it over to Dr. Burke. And let me stop sharing. There we go.
Everybody has a great, very thorough presentation. Really,
I can't believe I fought through the fire alarm. We're safe here. As far as I know, the house, it didn't burn down.
That's funny. We're going to save questions to the end. And I'm going to introduce Dr. Burke now. Dr. Burke is an associate professor of surgery at Ohio State University. She's board certified both in general surgery and complex surgical oncology. And in addition to breast cancer, she's also specializes in the treatment of melanoma and soft tissue malignancies. She received her medical degree from Vanderbilt and then did her general surgery residency at the University of Minnesota. I was fortunate to be involved in her training, and then she completed her fellowship at the Moffitt Cancer Center. Throughout her career, she has received multiple education and training awards. She has been an active researcher, and she's a member of the Society of Surgical Oncology Breast Disease Site Working Group. Dr. Burke is committed to improving the outcomes of breast cancer patients in low and middle income countries. I think she's been going to Honduras for almost a decade, and she's been leading breast cancer surgical brigades there. So I want to introduce now Dr. Erin Burke, a good friend of mine, to talk about management strategies of these high-risk women. Thank you, Dr. Burke.
Is that showing up as a slideshow, I hope?
We see it.
Okay, perfect. Thank you for that introduction and the opportunity to speak with you all today. We're going to, is that advancing?
Yes.
Okay, we're going to build on the discussion already had to talk about risk reduction strategies in these patients that we now know how to identify as high risk. And these risk reduction strategies come in multiple forms, including lifestyle changes, endocrine therapy use, and risk reducing surgery. And then we'll do just a very brief consideration of all that is necessary to employ these risk reducing strategies. So lifestyle changes are changes aimed at modifiable risk factors associated with breast cancer. Much of the data on the impact of breast cancer risk when changing these modifiable risk factors come from studies of the general population. However, they are applicable to many patients at high risk for breast cancer. So multiple studies have shown a decrease in breast cancer risk with increasing physical activity. In the French E3N population-based cohort study, there was an essentially inverse linear relationship between breast cancer risk and moderate activity. Similarly, in the Women's Contraceptive and Reproductive Experience study, individuals with activity levels exceeding the median activity level in the active control group showed a 20% risk reduction in breast cancer. This was also shown in the radiologic technologist cohort study, in which it was observed that women practicing walking or hiking for more than 10 hours per week had a substantial risk reduction, or the highest risk reduction seen as it relates to breast cancer, compared to those who reported no walking or hiking. There have also been multiple studies showing a link between increasing alcohol consumption and breast cancer risk, with breast cancer risk increasing with even low levels of alcohol consumption. This is all happening in a background where we're seeing increasing alcohol use amongst women, particularly young women, over the past several years. As such, a number of organizations have put together education items such as these to help women understand their risk as it relates to alcohol consumption and breast cancer. While the relationship between alcohol use and physical activity in breast cancer seems fairly straightforward, the relationship between weight and breast cancer risk is a little less consistent. It seems to be modified by menopausal status, with patients having a higher BMI that are postmenopausal having a higher risk of breast cancer, whereas for those premenopausal women, a lower BMI has been associated with an increased risk of breast cancer. There has also been evidence that weight gain after menopause is associated with an increased risk for breast cancer. And not only is it a risk factor for the development of breast cancer, increased weight has also been shown to be associated with presentation at more advanced stages of disease as it relates to breast cancer. Furthermore, weight seems to have an even larger impact on the patients we're focusing on today, which are those at high risk. And in this prospective cohort study, we see that the impact of a higher BMI is even more significant for those patients at high risk for breast cancer, with an increase in risk in those groups. Additionally, hormone replacement therapy, multiple studies have shown an increased risk in breast cancer with the use of hormone replacement therapy. However, it's not simple enough to just say avoid that, because it remains one of our most effective treatments for vasomotor symptoms and genitourinary symptoms of menopause. And so a nuanced discussion about the use of this medication is quite important. One general approach that we tend to take is that hormone replacement therapy be contraindicated in patients with a definitive diagnosis of an ER-positive breast cancer. We generally try and discourage this use in high-risk patients, particularly those that may benefit from risk-reducing medications, because those two medications don't work together. For average risk patients, it's a conversation about risks and benefits, with a careful consideration of the duration of the use of the hormone replacement therapy and other potential side effects of the medication. We employ a lot of other alternative treatments and multidisciplinary approaches to try and address these issues to improve the quality of life of women while not increasing substantial risks related to breast cancer therapy. For example, we have a specific menopause clinic here where different strategies can be employed in these patients to find relief from the menopausal symptoms they may be experiencing. So multiple things to consider as far as modifiable risk factors. None of them always straightforward and easy, particularly as relates to weight management, but a lot to discuss there. So what about endocrine therapy? Endocrine therapy, also known as risk-reducing medication or chemoprevention, leverages agents that have been historically used as adjuvant therapy for patients with invasive breast cancer or DCIS. The majority of the studies that focus on the use of these medications in women were in women considered high risk for breast cancer, although there are some exceptions. But this definition of high risk is somewhat variable, and it remains variable today. You can see that across our guidelines in the US with lots of different possible definitions for what makes a patient high risk. Additionally, many of these trials had either limited numbers of patients with pathogenic variants or excluded these patients altogether. So what are the options for these agents? There's two classes that are used for risk reduction today: the selective estrogen receptor modulators, or SERMs, and the aromatase inhibitors. The SERMs work by blocking estrogen receptors in different tissue that contain them, and they have different impacts in different tissue. So for example, in the breast tissue, it helps to shut that down and decrease the risk of breast cancer recurrence in patients that have a history of breast cancer, or the development of new breast cancers in the setting of prevention. Aromatase inhibitors actually block aromatase, blocking the conversion of other sex hormones into estrogen and progesterone. SERMs are the only medications with FDA approval for breast cancer risk reduction. However, there have been studies that show a benefit of anastrozole and exemestane in risk reduction. And so these agents have been included in a number of our guidelines for the use in high-risk patients. So the data for tamoxifen, one of the key studies that looked at this is the NSABP prevention trial, or P1 study that was already alluded to, which was a randomized controlled trial looking at placebo versus tamoxifen given for 5 years. It included women considered to be high risk based on the GAL model, which you've heard about now, or those patients that had a history of LCIS or were older than the age of 60s. They enrolled over 13,000 patients. The majority were over the age of 50. 6.1% had LCIS, 9.3% had an atypical hyperplasia, either ductal or lobular, and the 5-year predicted risk was stratified below. And what we saw was that there was a significant reduction in invasive breast cancer for those patients treated with the tamoxifen medication. This risk also was true for our non-invasive cancers, such as DCIS and LCIS, where we also saw a significant reduction in those who had received tamoxifen. Of note, the risk reduction was most pronounced amongst those with atypical hyperplasia, with rates as high as 86% being reported. This wasn't the only study. There are a number of other studies that have looked at the use of tamoxifen, including the International Breast Center Intervention Study, which showed a 32% decrease in the incidence of all types of invasive breast cancer. The Royal Marsden Hospital study didn't show a significant difference in overall breast cancer incidence, but it did show a lower incidence in ER-positive tumors, which did line up with the data seen in the NSABP, where the predominance of benefit was in ER-positive tumors. And the Italian tamoxifen prevention study is interesting in that it enrolled all women that had a history of a hysterectomy, so not necessarily just at high risk for breast cancer, and found that for the general population, there was not a significant reduction in risk, but for those patients that were high risk, there was a lower incidence of breast cancer seen in those who received tamoxifen over placebo. This isn't our only agent that we have available to us within this category of SERMs. A number of studies have looked at the outcomes of raloxifene as it relates to reducing breast cancer risk, even though a majority of these studies actually had different primary endpoints. So in the Moore study, patients were randomized to raloxifene versus placebo, with the primary endpoint being bone fractures. However, they noticed a reduced risk of invasive cancer, so followed this study up with the CORE study, with 4 additional years of raloxifene for high-risk breast cancer patients, patients at high risk for breast cancer. And this confirmed a reduced 4-year incidence of invasive breast cancer of about 59%. Similarly, in the Ruth study, which was looking at the impact of raloxifene on cardiovascular events, it did show a reduced incidence of invasive breast cancer by about 44% as well. Again, the predominance of the reduction came in our ER-positive tumors, but persisted nonetheless. So then the question came of, well, which SERM do we use? Tamoxifen certainly for our premenopausal patients, but what about for our postmenopausal patients? And so this was the primary aim of the follow-up NSABP2 prevention trial, or the P2 study, which randomized patients to either tamoxifen or raloxifene for 5 years. And again, included patients considered to be high risk, but they did need to be postmenopausal. The initial data from this study actually showed no difference in invasive breast cancer incidence between the 2 arms. There was a non-significant trend towards lower incidence of non-invasive disease in the tamoxifen group. However, in follow-up, we saw quite a bit of a change. Updated with longer-term follow-up in 2010, this actually showed that the incidence of invasive breast cancer was improved with tamoxifen compared to raloxifene, with raloxifene being estimated as being 76% as effective as tamoxifen. On the other hand, that difference that was not statistically significant seemed to narrow as it relates to the risk of non-invasive disease between these 2 agents. So it seems like maybe we had a winner, except the risks have to be weighed against the benefits. And what this study also showed was that there was a statistically lower rate of invasive uterine cancer and thromboembolic events for those that received raloxifene. And so consideration of which agent is used needs to take into account not only the maximal benefit, but also the risks that could be associated with that medication. So what about the AIs? What if we want to try to avoid these thromboembolic events or the potential risk for uterine cancer? Well, the data on these did come later, and they're used only in postmenopausal agents, with 2 agents primarily focused on with regards to prevention: anastrozole and exemestane, or Avista is the other name. And so in this international randomized controlled trial looking at placebo versus anastrozole, they included postmenopausal women considered to be higher risk than the general population, as noted here. They enrolled nearly 4,000 patients, and what this showed across a differing top follow-up period was that the anastrozole arm had a reduced incidence of breast cancer compared to the placebo arm. And so it did seem that, like the tamoxifen raloxifene studies, there was persistence in this benefit over a longer period of time. There was also a decreased risk in the incidence of DCIS in those treated with anastrozole as well. In the study focusing on exemestane, it was also an international randomized controlled trial of placebo versus exemestane for a shorter duration and shorter follow-up. This also included postmenopausal women with risk factors that suggested a higher risk of breast cancer, as well as those who actually had had a history of DCIS treated with mastectomy. And they enrolled about 4,500 patients with a median GAL score of 2.3% at 5 years. And the annual incidence of invasive breast cancer was significantly lower in the exemestane group compared to the placebo group, with an estimated reduction in risk of about 65%. Similar to the other studies, it also showed a decrease in the risk of non-invasive cancer, such as DCIS. It also showed a decrease in the number of high-risk lesions, such as ADH and ALH. So what we know is both are effective at risk reduction for breast cancer in high-risk patients. Neither have been shown to consistently improve survival. No prevention trial has been done that compares SERMs to AIs in a head-to-head fashion. There has been studies like this looking at DCIS, but not in a true preventative fashion. And the side effect profiles are notable for both agents, but do differ between the two groups. For SERMs, we worry about risk of thromboembolism, endometrial cancer, and cataracts. And for aromatase inhibitors, we worry about arthralgias, decreased bone density, GI complaints, and both are known to have significant symptoms related to menopause, such as hot flashes, mood changes, and weight gain. And so with medications as effective as this, one does have to take a pause and think about whether women are really inclined to take these medications with these kind of side effect profiles. And that is exactly the issue at hand. The uptake in the use of these agents is quite low, with only 5% of patients that are eligible for risk reduction with these medications taking them. There are multiple reasons that have been reported in the literature related to this, including lack of knowledge about these medications, a lack of understanding of their risk, concerns about effectiveness, lack of access to specialists who are able to assess a patient's risk and feel comfortable prescribing these kind of medications, and then, of course, side effects. So starting with low-hanging fruit, one possible solution that has been considered to improve adherence to these medications is lowering the dose of the medication such that the benefit is maximized and the side effects are minimized. This has been borne out in the TAMO-1 trial looking at low-dose tamoxifen or baby tam, which is tamoxifen 5 milligrams per day versus placebo. And this study included women under the age of 75 with ADH, DCIS, or LCIS. And what this showed was that there was a significant reduction in the cumulative incidence of invasive breast cancer in both breasts with those taking baby tamoxifen. But perhaps most impressive is the absolute lack of difference in side effects, with the exception of hot flashes, between those taking tamoxifen and those taking placebo. So in summary, when considering risk reduction with endocrine therapy, we have two different groups that are available to be chosen from: SERMs and AIs, both of which are effective at risk reduction agents, primarily for women aged 35 to 7, given that was the age range usually used in our studies, and those at high risk of breast cancer. The largest risk reductions are seen in patients with atypical hyperplasia, and we have limited data on the impact of endocrine therapy and those with pathogenic variants, although there is some data suggesting that it may be beneficial in certain BCRCA pathogenic variants. Side effects must be considered when deciding if and when to use these agents. And use of these agents amongst women at high risk currently is low, and further interventions to improve uptake in these medications could have significant impact on outcomes for patients. Excuse me. So let's switch gears. Another alternative for risk reduction is surgery. So bilateral risk reducing mastectomy, also known as bilateral prophylactic mastectomy, is the removal of both breasts in patients without a known cancer to reduce the risk of a future cancer. This can be done with a skin-sparing approach or nipple-sparing approach and can be performed with or without reconstruction based on the patient's preferences. What we know about this procedure is that it is effective at reducing the risk of breast cancer. In studies looking at this risk reducing option, we see estimated risk reduction of 90 to 95% in BRCA1 and 2 pathogenic variant carriers. However, the survival benefit is limited at best and is really limited to our highest risk patients and those who are young, with the biggest benefit for this procedure being seen in patients that are younger when they undergo a risk-reducing mastectomy. The most common complications include infection, hematoma, seroma, skin flap, and nipple necrosis and dehiscence, which at times can result in loss of reconstruction. It does eliminate the need for high-risk screening, at least routine high-risk screening that, as we've discussed, can be quite burdensome for patients with MRIs, mammograms, potentially ultrasound all being indicated. With regards to patient-reported outcomes, patients report generally being satisfied after undergoing bilateral risk-reducing mastectomy with high psychosocial well-being, positive body image, decreased anxiety, and minimal decisional regret being recorded in 2 recent systematic reviews. Of note, the satisfaction with outcomes does seem to be largely tied to the patient's ability to choose if and when to proceed with this procedure, as well as the reconstruction options that they are able to choose from. So when should we consider bilateral risk-reducing mastectomy? In patients with a pathologic variant in a high-risk breast cancer gene, such as BRCA1 or 2 or TP53, this is a time to consider. Patients with other pathogenic variants in certain moderate risk genes may also be considered for this procedure. Those genes such as CDH1, PALB2, PTEN, and STK11. Again, using other risk factor considerations can help us sort out who in this group is best suited for this procedure. Patients with strong family history, which admittedly is one of those vague guidelines. However, use of risk calculators can help us with a more objective measure of this. And patients with a history of chest radiation prior to the age of 30. So when should we maybe not consider bilateral risk-reducing mastectomy? Well, currently, there's insufficient evidence to support this use in patients with pathogenic variants that are considered lower risk genes, such as ATM or CHEK2, although we did see the huge variation we can have in some of these genetic variants. Patients with high-risk lesions in the absence of other risk factors, such as an extensive family history. These include things such as ADH, ALH, and LCIS. And as we've already talked about, these are patients who we would maybe instead consider risk reduction with medications, since these are very effective medications for this patient population. And then patients with significant risk factors that put them at increased risk for undergoing general anesthesia, advanced age, or competing risks such as ovarian cancer and maybe one of our BRCA population. When considering bilateral risk-reducing mastectomy, it does require an in-depth discussion that includes a discussion on the patient's risk as it relates to the general population, the estimated benefits of bilateral risk-reducing mastectomy, the estimated risks of both short and long-term complications of this procedure, alternative treatment options such as endocrine therapy, realistic expectations as it relates to cosmesis, and a true understanding of the patient's preferences. So we have a lot of options as it relates to risk reduction, but what one thing emerges that's clear is that it takes resources. You need access to screening. High-risk screening may include mammogram, MRI, ultrasound. You need access to treatment, because if you can't get treated, why get screened? You need access to specialists that are capable and willing to prescribe these risk reduction medications or offer these risk-reducing surgeries. And this is limited even in high-resource systems at times. You need access to the current state of detection and treatment and an understanding of where the gaps are and where we can make improvements to help in risk reduction. And I think this is coming down the line as we're seeing new areas of research emerging with conversations about risk reduction and screening in lower resource health systems across the world. So in summary, there are multiple risk reduction strategies available to patients at high risk for breast cancer. Lifestyle changes should be considered for all patients as they will have positive impacts across a variety of health issues. Endocrine therapy is an effective risk reduction strategy, particularly for our patients with high risk breast lesions. Bilateral risk reducing mastectomy is also a consideration for patients, particularly those with high risk pathogenic variants, significant family history, or a history of radiation therapy to the chest at a young age. And the risks and benefits of endocrine therapy and risk reducing surgery must be considered when counseling patients. I know that we've run over a little bit. Please forgive me for that, and we'll take questions.
Thank you, Dr. Burke and Dr. Beitch. I think, am I saying it right? Beitch?
Beitch. It's German, but you're not the first person to mispronounce it. Trust me.
Okay. Well, just, thank you so much. I think these are really great presentations, and I think some food for thought for everyone. I wonder if there are a few questions in the chat, maybe we could quickly go over. Well, there's one question: what is your opinion on the BCAN-Ray project? And then the second question is, why would letrozole not be used in prevention? I think at least we have those two standing questions. Maybe we could just kind of quickly answer those.
I'm unfamiliar with the BCAN-Ray study.
Yeah, as well. Yeah, I'm familiar with that as well. Something to learn here. As far as letrozole, I think this is an option. It's just a little less well studied in some of the larger trials, and so most of the guidelines outline the use of anastrozole and exemestane because of the stronger kind of research basis behind the use of those two agents. And then I just saw the chat. Sorry about my notes in the slideshow. I apologize.
Does anyone else have any other questions? I think the beauty of this is if we have gone over, we can continue this kind of on the website. If folks have questions or comments, or by email, and then we can always continue or answer the next time as well. So Miriam does say the BCAN-Ray project is a Manchester University NHS Foundation Trust study aimed at improving risk assessment in younger women.
Sounds interesting. I'm all for risk assessment in all women, and I don't know, men, maybe, I don't know.
And then there's another question that says, at what age do you recommend a mastectomy for BRCA mutations?
So this is a conversation that I tend to have at length with patients, certainly with testing not being recommended before 18. It gets us into at least a cohort that's hopefully, progressing into college or outside of high school. I generally talk to them about a time prior to when the first family member has had their breast cancer, but that's not a perfect tool. And then also serious consideration as it relates to child rearing and the desire for breastfeeding, which is probably the biggest point of the conversation as far as timing. It also can be impacted by insurance. A lot of our patients are on their parents' insurance until 26 years of age. Sometimes that's a consideration and uncertainty for after that age. But a lot of things do go into that consideration. I certainly think that as patients get older, I am much less likely to talk about it in a significant way. It's still offered, but if I have a 70-year-old in my office with their first breast cancer diagnosis, I'm not so worried about a contralateral prophylactic mastectomy in that patient. So a very individualized approach based on the patient's preferences, their goals, and the family history.
I would also add that if you look at the age risk curves and ask to me, the risk of breast cancer really doesn't go up until after 40, really 45. So you can delay it certainly until after child rearing, or at least after they've had whatever children they want to have. That's usually when I start discussing it. Um, Unless they're like Erin was saying, unless they're have a mother that maybe had breast cancer or even died early, those are highly stressed patients. They'll often get their child bearing out of the way early too, or not have children because of all the family history of cancer. So, but you don't need to, once this is the way I tell patients is once you've had a mutation that increases your risk of breast cancer, it's not an emergent situation. It's not really even an urgent situation. We can all take a deep breath and think about it for a little bit, and we don't have to do bilateral mastectomies tomorrow or next week or in the upcoming months. We're going and I follow lots of people with BRCA1, 2, PALB2 high risk patients, because that's their choice, and it's a shared decision making event and followed closely. I think that's a good strategy, certainly to get them beyond childbearing.
That makes sense. Thank you. Well, I think we are about 10 minutes over. Thank you both for your presentation. Anyone can submit questions online on the website. The next session in 1 month, I'm really excited about. We'll be hearing from my collaborators in Western Kenya, Dr. Lois Citiene and Dr. Catherine Niemeyer. They have a radiology collaborative, and they're going to be talking about breast ultrasound, especially in their experience using it in kind of the Western Kenyan region. So we can look forward to that. Thank you everyone for attending.
Still no fire. Everything's safe. Bye, everybody.
Bye everyone.